Good afternoon, and welcome to the latest episode of Let's Talk About It. My name is Bronte Burley Jones, and I am the founding president of the National Black Leadership and Empowerment Project. Our Let's Talk About It series was created as a platform for hosting critical conversations. It is our belief that we cannot heal, fix, or solve challenges that we are not willing to name and talk about. So in today's discussion, we will talk about Black women and their cancer experiences. This session is solely focused on a research project around Black women in recognition of Women's History Month and Sisterhood Month for the ladies of Delta Sigma Theta. Moderating today's discussion will be my college roommate, my line sister, and my sister for life, Dr. Alicia Jones. Dr. Jones is an alumna of American University, where she obtained her undergraduate degree in biological sciences. After college, Alicia was intrigued by research and continued her studies at Columbia University and the University of Pittsburgh until she decided that her impact for her community would be best served as a physician. She went on to attend the Philadelphia College of Osteopathic Medicine, where she earned a fellowship in geriatric medicine, which focused on disparities in healthcare in underserved minority populations. After opening her own practice and working directly with the community and local politicians for about 5 years, she wanted her impact to increase. So she moved to Washington, D.C. and entered the federal healthcare market. Alicia is currently a lead associate at Booz Allen Hamilton consulting firm in Washington, D.C., and works on various federal contracts that focuses on the advancement of health policy and quality management in healthcare and the ever-changing climate of health advancement. Most importantly, Alicia is a mom of all boys with a very big blended family that continues to stay aware of today's political and social climates that are very real for all men and women of color, and the threads of racial inequalities that go along with it. It is indeed my pleasure to turn this over to my dear, dear, dear sister, Dr. Jones. Please take it away.
Thank you, Dr. Jones. Well, it is an honor to welcome Dr. Johnson and Dr. Faulkner. I am very happy to welcome you both. And you all are a welcome pleasure today. We are here to discuss social disparities of health as it relates in different areas of healthcare. Social disparities of health is something that is a venue that has been within healthcare for not only decades, but centuries. It's something that is inherent within healthcare because as people of color within different communities, within different socioeconomic areas, we get different quality of care. We get different areas of care. And the question always comes up to why? Why? And why is it appropriate and why is it allowed? And in my background, I've always asked that question. Why is it that we are given less and it's always been allowed and it's always been accepted? And I'm bringing in two very skilled and appropriate doctors to let us know then their levels of knowledge at this point. So Dr. Johnson, first, Dr. Lashana Johnson, she received her bachelor's degree from Wesley College with a double major in sociology. She earned her PhD from University of California at Santa Barbara in sociology and completed doctoral certificates in human development and feminist studies. Dr. Johnson research interests included African American experience across the breast cancer continuum, faith-based maternal and child health education, culturally responsive program evaluation, and community-based mental health interventions. In addition to academia, Dr. Johnson has been very passionate within Black cancer survivors. She has focused her research currently in the next steps to att- to and now Dr. Johnson, correct me if I'm wrong. What I have is you have a non-clinical and non-biological approach to distress of the Black cancer survivors as they're facing and undergoing cancer treatment. One of her approaches is identifying strategies in the Black cancer survivor and their practical approaches to approaching their distresses and how to engage family, friends, and others in engaging solutions. Am I correct, Dr. Johnson?
Yes, you are.
Excellent, excellent. I also then welcome and and Dr. David, and again, forgive me, Dr. David
Fakunle.
Thank you.
You're welcome.
Dr. David Falkunle. Dr. David Falkunle is a self-described mercenary of change, something that is extremely intriguing for me, and I look forward to engaging this conversation. Dr. Falkunle is true to his last name, which derives from Yoruba, God of wisdom. David has acquired his insight and perspective through his 20-plus year career as a researcher, mentor, advocate, and a performing artist. It was the experience of transformational storytelling in his life, coupled with the encouragement of his persistent instructor, that compelled David to start Storytelling Project in November 2013. The project ultimately became Discover Me, Recover Me. David believes in the presence and the power of love in every person and serves to help others harness and fearlessly proclaim the stories of their journey. These two engaging, I say transformative healthcare providers right now, I think are kind of at that tipping point for healthcare. And I am very interested first with Dr. Johnson, if you could provide for me some of the background of how you see our healthcare agency right now, our healthcare industry as you see it, in how it approaches in social determinants of health, and even how it approaches our community as a whole, and how you see your place in that approach.
Thank you, Dr. Jones. I'm so glad to be here today to have this conversation with you and with David. So a bit about me that I hope helps give some context for the work that I do. I am now, as of December 2020, a 3-time cancer survivor. I was diagnosed first with cancer in high school. My father is self-employed. He's an auto mechanic, and we didn't have health insurance. So this is many moons ago, pre-ACA. And so I grew up in a community in Tulsa, Oklahoma, that's in the shadow of Black Wall Street. I grew up in a food desert, meaning we didn't have large chain grocery stores. I went to a school that got closed because of the poor test scores. There were very few pharmacies. There was no hospital in my community. And this wasn't because the people in my all African American community weren't interested in these resources. It wasn't because they didn't have the same goals and dreams that other people have for their kids, for their families, for long, healthy, and productive lives. It's the historical impact of things like redlining and racist structures around education and provider racism, that we didn't have those resources in our community. And as a result, I grew up surrounded by people dealing with chronic health conditions like diabetes, A number of folks in my family died of cancer. My father's mother died of what we think is an untreated brain tumor. She died on the way to the hospital after months after not being taken seriously about her headaches. So when I come to my work, I think a lot about all of that context that surrounds Black women throughout the United States when they are joining the cancer continuum. And the continuum starts essentially from birth. When you're born, all the exposures you have in your community, all the genetics, all the things can increase your risk for cancer. And we know that African American women, as compared to their white peers, are dying at higher rates than the white peers, regardless of age, regardless of stage at which they're diagnosed, regardless of type of cancer. We know specifically for breast cancer, which is one of the ones most people think about, African American women, according to the American Cancer Society, die at a rate that's 40% higher than white women. And back in the, I'd say, 80s, we thought, well, maybe it's just because folks don't have access to early screening. But we find, as we've been digging into the research and more programs have made mammograms and things like that available, that's not the case. African American women get mammograms roughly at the same rate as everyone else. The answer lies often in late diagnosis. So they don't have a medical home, they struggle to navigate the system, or they don't have health insurance. Often there's a little bit of difference in biology and genetics. So as we know, broadly, African Americans have not been participating at the same rates in clinical trials. We don't have a sense of what these different kinds of diseases, so breast cancer is multiple diseases, lung cancer is more than one disease, gynecological cancer, it's multiple diseases. We don't always know how these show up for African Americans and when and why they're often showing up at earlier ages. So especially with breast cancer, African American women are diagnosed often in their 20s and 30s. My first breast cancer was diagnosed when I was 30. So that's a bit of how I come to this work, is that I'm thinking about all of those spaces where there's a story there that we don't yet know. That's a clinical story, but there's also a personal story. So like I said, I'm a cancer survivor, and I have members of my family who chose not to seek treatment for their cancer or to stop treatment. We had complicated conversations in our family about the role our faith would have in deciding what treatments to uptake and which ones to not take up. We talked about family support and other things that were going on in my family that might make someone hesitate to go get screening because they're dealing with other things. They're helping a family member with another health issue. They're helping a family member that's a victim of violence. And so as African American women, we often end up deprioritizing our health because we're caring for the health of our communities. And as we think about women in our community who are active in social justice issues, sometimes that care extends to the broader community. So not just our immediate biological family, but the broad family of the Black community. We're focusing on those. But we've also started to see research that says, let's think about the genetic memory of all this trauma, of all these experiences. Does that tell a story about why we're seeing these rogue cells in someone's body turn into cancer at ages that are unexpected, or at rates at which were faster than we would imagine they would be? So that's how I come to this work, is thinking a bit about family and faith and community, thinking a little bit about justice, thinking a little bit about health communication, which is the last area I'll say, that I grew up, like I said, without health insurance most of my life. So didn't have a really strong connection to a medical home. We had a primary care that we would sometimes see, but no close personal relationship. So once I was realizing that something was wrong with my first cancer, which was a Hodgkin's lymphoma, and they were just throwing antibiotics at me because that's the cheapest and easiest thing to give to someone without health insurance who seems to have lymph nodes that are swelling and all of that. I didn't know how to advocate for myself in that space. I didn't know how to talk and ask questions and ask for a second opinion or ask to see a specialist. So it took months before I got that diagnosis. And so I ended up eventually being diagnosed in stage 2, even though I had demonstrated symptoms probably in the summer, but wasn't diagnosed until November. And so those are the places where I come to for this work.
Very good.
And as a result, I've done, not only research, but I, for a couple of years, was a co-chair of the African American Breast Cancer Task Force here in Omaha. And we trained African American women to do peer health education in non-clinical settings. So they would help folks sort of learn how to talk to a doctor and the right questions to ask. We'd give them little wallet cards. So if they got a diagnosis or they were told they needed a biopsy, what to ask about, like why they're doing it, and who to ask and who should be in the room with them.
I can interrupt for a second, Dr. Johnson? That's you're going to next steps, which I think is spectacular.
Right.
Something that you brought up, I thought was very interesting, storytelling. And I think that kind of links in Dr. Falkley about his storytelling, because he has some very key aspects that I thought was this discover me, recover me, and this healing by loving. Can you go more into that idea and that concept that you have?
Well, this idea is not mine. This concept is not mine. I think what blows my mind about what I do with storytelling is that people see it as so revolutionary and so novel. It's not. Storytelling has been around since time immemorial. It is inherent to the human experience. This journey that I'm on is because someone saw an opportunity that I didn't know existed. So when we talk about that class project, that was Discover Me, Recover Me back in 2013, I didn't think that was possible. I went to Johns Hopkins. That's where I got my PhD. I did that because, hey, they say it's the best public health school in the world. I'm here to be an epidemiologist, blah, 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 all that same stuff. And I was okay with that. I realized that research was how I could contribute to making the world a better place. I had already made up my mind that that's what I wanted to do. And I figured epidemiology, in this case, with a focus on mental health, with a focus on looking at drugs, illicit substances, was the way I do it. And then this instructor created a different opportunity, and it involved an art form that I had been doing since the age of 9 in a professional context. And it completely changed my perspective on what I could bring to the public health field. But the concepts are not new. That's the whole point. You talked about, inequalities in healthcare, in public health, we talk about social determinants of health. That's all important. Trust me, trust and believe, all of that's important. But what does that actually mean when we say social determinants of health? So when I say your race makes a difference, what does that mean? When I say your age makes a difference, what does that mean? When I say where you live makes a difference, what does that mean? That can become a buzzword very, very quickly if you don't have the context. So what storytelling brings is a context that currently in the healthcare field and in the public health field for sure, which is my background, we are lagging behind so much. Yes. But going back to that point about the loving, is that not what we want? Is that not what we want? Let's take ourselves away. So let's take away the PhD. Let's take away the MD. Let's take away the DO. It's LaShawn, it's Alicia, and it's David. Yes. What do we want in our lives? To love and to be loved. That's it. So it really is just a reminder of what's most important with our existence. And no matter what your faith, no matter what your belief system, you got one shot at this thing called life. What are you going to do with it? How do you want to be remembered? So again, when you make that, and I put it in this way because I think that makes it real for people. When your time comes, if you are fortunate to be able to reflect on your life before you transition, what are you going to be thinking about? I guarantee you will not be thinking about social determinants of health. You will not. You'll be thinking about what I call the existential determinants of health. And here's what they are. And I want to say it freely, loudly, and I want people to use it. Not to give me credit, but again, it's a reorientation of how we can look at ourselves and how we can look at health overall.
Yes.
Were you acknowledged? Were you appreciated? Were you respected? Were you understood? And were you loved? That's it. And from those things, you can look at any trajectory of health that you want to. So for me, storytelling was a way to remind myself ultimately, because trust me, I'm the biggest pet project I have. To remind myself and to remind those with whom I work, my colleagues like LaShawn, you know, clients, partners, collaborators, whatever the case may be. Yeah, there's a bunch of issues that we got to work on. Like you say, a bunch of crap that's happening. There's a bunch of crap that we got to work on. But when we boil it down to the core, the nucleus, what matters? To me, those are the things that matter. So our policies, our interventions, our programs, our research should reflect those things. And this project that LaShawn and I are doing aims to reflect those things. These are the nuances. These are the themes that go through the minds and the hearts of Black women as they are navigating the cancer spectrum. From the point of, yes, go ahead.
I'm sorry. So let's get to that. That's a very good point. So you guys right now, individually, you guys have very key objectives. David's looking at how we are seeing ourselves. What is our key nucleus? What are we thinking? LaShawn is seeing the cancer survivor, the things that they are dealing with. So you guys are seeing the same thing and approaching it from different perspectives, which I think is spectacular. How collectively are you guys merging these efforts, and what are you guys seeing as your project? And I welcome either of you to begin first.
Go ahead, LaShawn, you the lead.
No, David. David, I think we actually decided you were going to do this, right?
Okay, all right. Yeah, that's true. We did say that, didn't we? All right, here we go. So you're right. We do have different approaches and different angles, but they do work collectively. So yes, it's, as I mentioned before, it's important to understand context. I can't help but to go back to my own education. You know, again, Johns Hopkins, it's not to call out Johns Hopkins, it's just that's where I learned this stuff. This is where I learned public health, my theoretical, conceptual foundation. I still remember it like it was yesterday. The class that I took my fourth term of first year was about bias. And the point of that class was that bias was bad. Do everything you can in your research capacity to eliminate and reduce bias. As I continue to grow as a researcher, as an academic, as a person, all these things that I do in public health, I learned to realize that it's not bias, it's context. And we wonder why there is such limited efficacy and limited efficiency when it comes to, again, programs, interventions, and policies, as it pertains more likely than not to people of color, because it doesn't include our context at all.
Oh.
Because you have enough professionals that have been trained and conditioned to call it bias. So we don't want that. So you can look at any health outcome. It can be anything on the cancer continuum. It can be diabetes. It can be heart disease. It can be anything. If it doesn't reflect the context of the population that is affected by the health outcome, it will not work as well as it should. And it may not work at all.
Yes.
So for us, this is our opportunity to show and demonstrate the importance of context with something that we know affects so many people in this country, like cancer. The experiences of cancer is not a monolith. Not everyone experiences cancer the same way. And LaShawn told her story. I'll tell my story. So my maternal grandmother died of breast cancer in 1979. She was in her mid-40s. I never met her. So she is only a legacy that lives on in my family. My father is currently dealing with prostate cancer. That diagnosis came about a year ago. I can tell you, it's been a journey, not just for me, but a journey especially for my father. And even looking at how he approaches navigating his prostate cancer, it reminds me it's not a monolith. My father, and I'll say this because I don't know if he'll ever see this, but my father, he'll treat it like the cold, like the flu, like the pneumonia. And the sense is that, yes, this is bad, don't get me wrong, but I'm not going to demonize this. It's a health outcome. It happens. So I'm going to treat it just like I would treat everything else, be attentive to it, do what I need to do, and keep it moving. So I say all that to say is, if you didn't know he had cancer, you wouldn't know, because he's not going to tell you. That doesn't apply to everyone. There are people that need to tell you that they're dealing with this horrible health outcome, because it's affecting them emotionally, is affecting them physically, certainly, is affecting them spiritually, is affecting them psychologically. And then when you add on these additional contexts, being black, that's a context. Being a woman, that's a context. Being a caretaker, that's a context. That's going to affect how you navigate this experience. Are you seeing that in research papers?
No.
I'm not. Are you hearing about that in conferences? I'm not. So how is that translating to the way Black women are treated when they're dealing with their cancer? How is that translating to the way they navigate the healthcare system? Is not doing them well because the context is not included. So we're using various forms of narrative. Again, yes, I am a storyteller, loud and proud. We're using forms of narrative because it is relevant to our cultural context. We, as Black people, members of the African diaspora, we do storytelling. It's natural for us. So the way that we pass along insight, wisdom, and information comes through our story. LaShawn and I are providing a space where Black women who are dealing with this health outcome, a serious, life-changing health outcome, can, if nothing else, tell their story. If nothing else. As researchers, we know that their stories will provide us valuable information into the context of how they are navigating this life-changing experience. Not just them, how are their families navigating? How are their friends navigating it? What does it mean to be a Black woman, first and foremost? Secondly, what does it mean to be a Black woman dealing with cancer? Because those are contexts that need to be understood. And we're doing this, again, not just to inform our colleagues in the healthcare system, our colleagues in the public health system, but for the healing aspect of this. There are a lot of people who have lost their social networks because of COVID-19 and the pandemic. So those who were going to support circles, that were going to spaces, they don't have it the way they used to. They're looking for an alternative. They're looking for a sense of connection like they did, with people who are united by the same general experience. That is what we're providing. And oh, by the way, we're capturing this rich, deep, contextual information that will help us inform how to better serve, that's the point, serve Black women as they're dealing with cancer.
Very good.
Sean, did I miss anything?
No. You got it.
Good.
But it gives me an opportunity to address the question I think we've got from one of our Facebook viewers. So it looks like we have a question that says, what can we as community members do to help reduce bias or increase awareness of context in medicine and cancer treatment? And David's already teed me up really well for this.
There you go.
And thank you. As always. So I'll give a couple of examples to the person who asked that question. So as I mentioned earlier, one of the ways that I think about addressing bias and thinking about context was that with my late great colleague Jackie Hill, we started the Nebraska. We changed the name like 50 times, but it was the African American Breast Cancer Task Force, and we had two arms to this task force. So I mentioned earlier that we did peer education. We educated Black women. It was Black women educating other Black women about the things they needed to be aware of, things like triple negative breast cancer, which disproportionately impacts African American women, about what family history means, what genetics mean, what's missing in the genetic information that we have. And so they could go out to churches and schools and dance clubs and talk about that. But the other thing that we did that was really important to me and Jackie as we did this work is we also brought some of our peer educators, we call them advocates, to a regular meeting of folks who were representatives of the hospital system around town. So I'm in Omaha, Nebraska, so there are a few major hospital systems that are available. And we had these women telling their stories about what it was like for them to navigate these hospital systems, whether it was diagnosis or treatment or having a family member in the room with them, but also what they wish people knew about them, what they wanted people to show and tell them and ask them about, whether it's from transportation to childcare to the timing of appointments. They wanted someone to ask them about that. We were really fortunate in that Jackie had a group that was a support group that had a history of partnering with people to help them go, like as a patient navigator to go with them to appointments. So we already had a space in the hospital where we could use that as an option. So I would say to folks, as if you're working in public health, if you're working in healthcare, if you're just working in community organizations that touch women around the community, those are places to do it. So getting on advisory boards in clinics and hospitals, getting in front of people like me who are professors. So this fall, I brought in some community members to talk about their experience of being Black and navigating the healthcare system. We had a panel, the community members facilitated the panel. I just was a fly in the room, and we had health science students in the room listening to these folks tell their stories. So someone talked about having COVID, someone talked about mental health, and then someone talked about cancer. So finding those opportunities are really important, getting folks early on in their careers, but also working together and in these spaces for women, whether it's at churches or other places, to let them learn about the information so they know what to ask, what to look for, how to feel comfortable with just talking amongst each other about what was going on. I have been surprised in the previous projects I've done in the African American community around cancer is how often people don't find out until after they have cancer that they have a family member that had cancer that didn't talk about it. Or there's somebody in their church that's like, Sister so-and-so had cancer, you could ask her about it. But we weren't talking about it in the open. People were experiencing things that I should have been watching out for, whether it was lumps or changes in my breast, and just no one was talking about it. So I found our group gave us that place to do that, where people were given permission to say, you can go ahead and talk about this. You can have a 14-year-old daughter and you can start to give her breast health awareness. And that's okay. It's not sexualizing her. It's making her aware of her health. It's empowering her.
That's a question that I had for both of you, because what it sounds like that you all are doing while you're actually researching this with the storytelling and allowing for the conversations to be had, you are informing and giving the information to people that it's okay and it's a safe space to have the conversation. Because culturally, what we do is we tell stories. And what we do is we sit around, and whether it has been centuries prior or even now, we sit around and we tell stories. But now what we need to do is to inform and acknowledge that there are some pain stories that need to be told of illness and awareness. And as we're telling each other, what have you guys learned in this being aware and being safe, and then and telling, as you guys have gone out and told groups of people, what have you learned of an increase? Have you learned, I should say, an increased awareness, or have you learned people looking for more information and pulling from you?
That's an interesting question. I would say to your point about telling the stories of pain, so much of the Black experience is defined by resiliency.
Yes.
You know what I mean? Like, you don't survive 400 years of the crap that we've dealt with in this country without being resilient. And I think that becomes like the primary virtue in so many Black households. So we only talk about survival. We only talk about our strength. We only talk about our resilience. We have to talk about the pain that we've endured as well. And it doesn't mean we have to focus on it exclusively, but we have to acknowledge it again. First existential determinant of health, acknowledgement. So acknowledge the total story. The things that we have dealt with and the ramifications of being in this country under these circumstances, yes, have been destroying our health from day one. We can acknowledge that. We can acknowledge that this existence under these circumstances is unhealthy. A lot of times, I'll tell you the number one thing that I've noticed, even before, collaborating with LaShawn on this particular project, it starts with one. It starts with one person who is brave enough and courageous enough to share their truth. And there usually is a snowball effect, because someone is just looking for the okay, that it's okay. It's okay. So we call it vulnerability. And for me, I have learned to incorporate that in my work. So again, this whole idea of objectivity, that don't exist. No, every life is subjective. So the way you see this world is going to be different than the way I see this world. The only way we understand is if we what? tell the stories. So for me, in my research, it's important for people to know my context. So again, why do we do this? Why do we care? So why do we care about breast cancer or any type of cancer or the experiences of Black women with cancer? Because it affects us.
Yes.
I lost my grandmother because of this.
Statistically.
You know what I mean? LaShawn has dealt with this. So it affects us. It means something to us personally. We as researchers cannot be afraid to say stuff like this.
Yes.
To say that there is a context for us that drives the work, because we all have it. But these are usually the things that we say around drinks, or we say around, when we're at the conferences. I'm forgetting because I haven't been to a conference forever. The conferences, this is what we talk about. Why do we put up with the crap of academia? Because the work we do means something to us.
Yes.
So the meaning is important, and that can be a foundation for how we structure our work, how we structure our designs, how we structure our analyses to make sure that meaning is pronounced, that meaning is at the forefront of everything that we do. But when we talk about stories like pain, when we talk about trauma, because that's the sexy word right now, trauma, it takes vulnerability. I think part of the onus should be on the researcher to be vulnerable, to help encourage the vulnerability of others, because that's a responsibility. It's an honor when someone tells you their real story. It should be considered an honor. It should be something that's respected when someone tells you their real story, because I think we all have those experiences of where we thought we knew the story, but we didn't.
Right.
So you realize the honor it is when you actually know that person's truth. So to me, that's the one thing that I've learned is that, when you have that context, don't be afraid to express it. That's the point. We're modeling the behavior. We're trying to shift the paradigm. Well, it starts with us. We can't ask of something more than what we can give ourselves. It's accountability.
Yeah, and I definitely see you guys as care providers. You are definitely leading that objective forward, and you are shifting that paradigm, and much different than former care providers of being the stoic and the, okay, let me check your blood pressure, okay, go out and go forward. It's leaning forward and what else is here. And that less objective and more subjective narrative of what else is what is more encouraging, I think. But LaShawn, you were saying something for me.
So I want to say a little bit about what was the impetus of getting some of this work started.
Please.
So I became aware a few years ago. I think I knew about it, but I don't think I really thought about it. This idea of these tools that are often psychometric tools that are out there that are distress thermometers. So distress is in our title, and you mentioned earlier about distress. And it's this idea, there's already data out there that if someone's experiencing distress around personal things or spiritual things or practical things like transportation, they have less good outcomes for cancer because they end up missing appointments, or they end up being so stressed that they get sick and so they have to delay a treatment, or they end up having to take medication or be hospitalized for something else because they can't manage these things that are part of life, right? And so, but one of the things I started thinking about when I was reading those things is that we already know, like when it talked about insurance, like some of the tools ask if someone has insurance, or if someone struggled with money, or if someone struggled with housing, or if someone is struggling with coordinating childcare or elder care. And I started to think that we know, based on Black women's experience in the workplace, Black women's experience with income, the neighborhoods that I talked about I grew up in, we already know that Black women are experiencing a disadvantage of that even before the cancer diagnosis starts. And so we've got this layer of cancer and of these stories we've all been hearing, that I had to go run and help pick my sister's kids up, and I had to do those things. So it's baked into that, these distress tools that African American women are just not going to do as well. But for me, there was no conversation about, well, how do you address that, right? If you already know from day one that these things can impact someone's ability to navigate the cancer care continuum, why aren't we having a specific conversation about Black women who are starting way farther behind? They're already behind just in life in general around some of these issues. And so when I started thinking about that, because I wanted to make a positive contribution to how people navigate this continuum that starts from birth to death. Because I don't think of myself as a cancer survivor until I die of something else. How do I make a difference there? So I knew that I needed to get these stories so that I could start to share what I'm learning from these stories. I'm learning from these experiences. Some of them I already know because I'm living it. I'm living as a Black woman, so I know some of these things, but I know my experience is specific, so I need to know other people's stories. But then how do I translate those into a conversation with providers and with patient navigators and folks who are signing folks up for Medicaid or those kinds of programs? I think that this is one of the unique spaces that we land in. So we've talked about how we talk about how storytelling is an important part of our community. We also talk about how we all know African American women have these intersectional experiences. Our next step then is how do we bring those things together in a way that's educational, that feels culturally competent, that feels empowering, but also acknowledges, like David was saying, both the trauma and the resilience in our experiences.
Okay, so then that leads me into an excellent, nice question then. So as you guys are building on this research, your next step forward, moving forward with the information that you obtain, as you gain, because that's a lot of information, the trauma, not only dealing with the cancer, these resilient people dealing with cancer, what next? Moving forward, what can we do with this information? How can we then start making that forward process a different one? How can we blend it to make it a different map forward? And that's always what my objective is as I'm working for patients, even on a federal, even on a grassroots level. How can we make that objective different?
It all comes down to power. If we can just be completely honest, it always comes down to power. So for me, I'll put myself out there. Put me in front of the people in power and let me tell the story, because I have the stories that say when we have an opportunity to share our truth, it's really hard for people to ignore it.
So David, you're saying in front of, you're saying get yourself in front of the leadership, the federal leaders, or the what do you?
We need to start local. No. So much of the impact is local. We know this.
Understood.
Even if we're talking politics, the politics is local. You know, the federal stuff makes the news, but the local stuff is what makes the difference. So for me, it is the leaders of healthcare. So, you know, if I'm talking Baltimore, I need to talk to the president of Johns Hopkins. I need to talk to the president of Mercy Medical. I need to talk to the president of the University of Maryland. And we need to let them know is the way that you are treating Black women as they're experiencing cancer is not conducive to their health. And if nothing else, they will know the truth, and then they could decide whether they want to adjust their practices, adjust their policies, and adjust their work accordingly. But they can't say they don't know. One of the things that I'm learning in my career is there's just a lot of people that just don't know. So I can't call them ignorant. They haven't had the chance to ignore it yet because they don't know. So for me, this work is about translating into policy. It is about translating into better practices and into better interventions. But you have to get to those in power who can implement the knowledge that we have. So to me, those are the next steps. And it's about empowering those that we have the honor to chronicle in this journey as well. So they can be advocates for themselves as well. We see what advocacy can do. We see what activism can do when you have critical capacity. Things can change. So it is about the organizing of people around this experience to say, I deserve quality health and I deserve quality health care, and the color of my skin and the type of configuration of my chromosomes shouldn't change that. That's the point. That's the point. But they got to hear the stories. I'm telling you, the statistics only take you so far. That's why we're in this mess, because too many people are relying on statistics to tell you all that you need to know. You need to listen, not just hear the stories. Listen to the stories. Extract the humanity which will be ever present in any story that you hear about a person, let alone a Black woman, experiencing cancer and dealing with that. How does that not speak to you
Yes.
if you call yourself a human being? So really, ultimately, what this is doing is this is further evidence of how we can challenge the humanity of people. You tell me that you're human, prove it. Listen to this story and tell me that you're not changed. Listen to this story and tell me that you're not moved. Listen to this story and tell me that you won't do something to make it better. That's the challenge.
So I want to piggyback really quickly on what David said. When we're thinking about small p and big P policy, so you, Alicia, you were talking about federal policy, and then David was talking about local, but I even think even smaller, like smaller institutional policy. So we're talking about participatory medicine. We're talking about hiring policies, having more staff and providers that look like the people from the community that they're serving. We're talking about something that you didn't mention about my background, Alicia, is that I'm a participatory evaluator, a culturally responsive evaluator. And one of the things that I think that's important when folks talk about how to get involved and how to make the change and what does that change look like, because we can do our best to sort of march up to the door and say, you should change this. But one of the ways we make that change is with culturally responsive evaluation or race equity evaluation. So getting the people most impacted by the issue involved in the evaluation process. So when you say, I'm going to do culturally responsive evaluation, that means Black women are part of the team. That means Black women's voices are lent to say, this is how this policy around setting the age for the first mammogram at 40 has impacted Black women. That those numbers and those stories matter. And so when we go in and we say we want to make system change, yes, research is really important, but I want to make a passionate plea for that evaluation part, because we bring that as part of our story. So what David and I are starting to do is we're starting to reach out to African American women because we want them to participate in these focus groups about their cancer experience. And those focus groups, even though they may feel like, here's my one story about my cancer experience, what they actually do is help us make a case for why some of these policies and practices in public health, in medicine, aren't working for Black women. We can take what we have learned,
Right.
and we're going to be doing some poems along with that, but we can take what we learned and we can connect it directly to a policy that's operating in a clinic, in a hospital, for recommendations for who gets colonoscopies or mammograms, and we can start to connect those dots for folks. So some folks need that help, like David said, they just don't know.
Right.
And that's what your stories, your sharing your information with us helps us do. It helps us make the connect the dots between this personal, because the personal is political, but this personal story, and then these broader policies that impact all of us and why they need to be changed, why a process needs to be changed. That gives us the strength to make that argument when we walk in the door and say something needs to happen that's different.
One of the things that I want to open up right now to the audience, if anybody has a question for any of our colleagues right now, I open up that for open discussion. But as we're waiting for questions to come up, I think it's very interesting because as I have been practicing, and I was actively practicing in Philadelphia, it's interesting, LaShawn and David, as I was doing a lot of that, knocking on individuals' doors and helping and learning the stories. And I noticed a lot of my colleagues were doing a lot of the similar things, but there weren't enough going into the administrative offices. And that's kind of where I said, while I was one of the few and the only, I was going to take that objective. But I'm really glad, David, you made that point of we need to get in front of administrators on different levels. But you're right. We need to start telling them there are stories that right now, what I'm doing is bringing numbers in front of them. But stories are important, because that's where I learned it. I learned it from the stories, and that's what touched me. Because within our culture, like I said, our culture, I feel stories touch. But I'm talking to people who are not looking like me or feel who that I perceive that don't always engage maybe like we do. But it's a different objective.
So I'm gonna push back gently on that.
Yeah,
It's
please.
conditioned to think that the stories don't resonate. Oh, they do. I do this in front of more white people than I probably do people of color. I do, and it works like a charm. It really, really does. So I don't want us to think that white folks are so disconnected from their humanity that they can't recognize. Yeah, they do. It may not be as profound as it is in our culture, because it's really profound in our culture, but it's there too. It's a universal practice, storytelling. So
Love it.
what helps me, and so let's bring it full circle. The reason I call myself a mercenary for change is because I navigate different spaces. I am an artist. I am a researcher. I am a teacher. I am an advocate. I am an activist. I am all those things at the same time. It's not meant to be separate. It's meant to be continuous at the same time. So in any space that I navigate, local government, state government, federal government, institutions, communities, organizations, you're getting the same person. How you know that is because the stories are consistent no matter where I go. I have no problem invoking love, understanding, justice, peace in front of my colleagues at Hopkins. Why wouldn't I? Because that's what it's all about to me. That's what it's all about. And when I encourage them, and it is all about encouragement, when I encourage them to look at their own stories, watch their hearts open up. All the labels, all the hierarchies fall away, because in that moment we are united around our human experience. So storytelling and the use of art as well, and I think that's the other point for me, is like arts and culture needs to be at the forefront of not only public health but health care as well, because it is an invaluable tool that allows us to activate and empower and utilize the context and nuances that can make the difference in a person's health trajectory. So yeah, bring the numbers, and it's not to discourage quantitative data. Don't get me wrong; that's what pays the bills. I can get it. You know what I'm saying? That's what got me my PhD, was the quant. But it's to be used in harmony with the stories.
Yeah.
So I put it this way: this is the best way that I've been able to explain it to people and help me understand it too. Quantitative data can help you understand or answer the question to who, what, where, when, and sometimes how. Qualitative data answers the question why.
Yes.
And in any situation, almost in any field, the number one question that we all have is what? Why? Why? So we have to be courageous enough, and we have to be humble enough to say that yes, person without the PhD, yes, person without the DO, yes, person without the master's degree, you have exactly what we need, and it's simply because of you and your existence. So if you want us to help be a part of the solution to improve your health, your well-being, the trajectory of your life, bring your wisdom, and the wisdom is in your stories. That's all we need.
Well, I wanted to finally just thank you both. You guys have offered much wisdom, much information, of which I think I definitely see the change that is coming to healthcare. If either of you have any closing remarks of what you would like to offer to the audience right now, please, Dr. Johnson, Dr. Fall.
I will start. I will make my closing remark is actually an invitation. So my name is LaShawn. I've been diagnosed with cancer 3 times. The last time was December 2020. I'm 45 years old. I don't see that many people who look like me at the cancer center. I don't see that many people who look like me in the flyers that I see. I want to talk to you. I want you to share your story with me and with David, So we are doing right now some focus groups that are virtual, that we want to make an invitation to you to participate in, so you can be part of this community of people who look like us. We need to get our voices louder. We need to get them out there. I don't want your daughter, your niece, your friend to have the experience that I have, but I know that some of them will. And I want you to know that there's a community out there that's there to support them. We stand on the shoulders of giants of the Sisters Network and the Witness Project, some of those groups out there that have been doing this work that I love and I have worked with before. And I see my work as continuation of the work that they do, but also an expansion. So my closing remarks are to you to say, you don't have to go this alone. There's a community of women out there who want to talk with you, want to fellowship with you, want to support you, want to laugh with you, want to cry with you, and I'm one of those people. So that's my closing remark, is just invite you to be part of our project, or continue to follow me and David on social media and see where we're up to. David?
Yeah, I'll just keep it simple because I can get long-winded, I know. Black women's stories matter, and we respect those stories. We want to cultivate those stories. We want to nurture those stories, and we want to tell those stories, with your permission, of course, to the world, so that your health, your well-being, your care is everything that you deserve. And it starts with you. It starts with your stories. So if you are so moved, if you are so inclined, please share with us your stories.
Thank you both, LaShawn and David. Thank you both. This was a wonderful conversation. Hope to be able to bring you both back just to hear an update of how well the research is going. You guys are on a journey that is spectacular, and I know you guys will be written in history books, and I look forward to reading them. Finally, I give it off to Dr. Jones.
Well, thank you, Alicia. Thank you, David. Thank you, LaShawn. As we've said before, these are conversations with us, including our experts, to the benefit of our community. So for those of you who were here with us live today, I want to thank you. But I also want to thank my colleagues. LaShawn was brought to my attention by a colleague of mine from Dickinson, who thought that we would make a connection. And I think, LaShawn, we were on the telephone for 10 or 15 minutes. And I said, let me call Alicia. Let me call Barbara. Let's make this happen. So I truly hope that some of you will be moved to connect with both LaShawn and David, because this is a worthy project. We know that health disparities exist, and they're creating a community where we can talk safely, in a safe space, about things that impact us in ways that others may not be attuned to. So again, Dr. Johnson, David, I'm not even going to try to mangle your name, brother. Thank you, thank you, thank you. And to Alicia, always there when I call you. So this concludes our latest session of Let's Talk About It, where we aim to have the critical conversations to fix the problems, the challenges that exist within our community. Thank you so much.